Well, welcome to the Dolan lecture. Tonight we are going to have a cozy lecture because I told the doctor that we'd have a booming crowd, but I found that a cozy presence will make the lecture much more effective. So without that, I'm going to have Dr. Lee introduce the speaker tonight. And thank you for coming.
John,
And while
I think we just empowered you. Thank you to the Dolan family, distinguished guests. I look out at this crowd and boy, I see a lot of friends from a few years ago and today. We've got the director of the ICU here, the emergency department, we've got vice president of the physician group, we've got the dean of admissions of Georgetown Medical School. It's a truly impressive crowd, and appreciate you coming out tonight. Heatherlee, you may want to sit because I have a whole page of items to introduce our distinguished guests. Dr. Heatherlee Bailey, she's an emergency medicine intensivist. Is that right? Does that exist?
It does.
Faculty member at the VA hospital down in Durham, Duke University. She completed her medical training at Rutgers. She's a Jersey girl that I found out. She trained there. She did her emergency medicine residency at the Medical College of Pennsylvania in Philadelphia. She joined the faculty and served as the director of critical care education and associate residency program director. That's a lot of power to decide who's going to come train with you in your program. Throughout her career, she's been dedicated to teaching, to education, development, mentorship, and her work has been recognized by the American Medical Association, the Women's Mentoring Award, multiple honors from the Society of Critical Care Medicine. She serves as a senior oral board examiner. That's a tough gig, right? Because you're going to pass, you're going to...
It's much easier on my side of the table.
There you go. Team leader for the American Board of Emergency Medicine, and her work in trauma critical care extends not only nationally but internationally, where she helped develop the comprehensive trauma life course in India. Dr. Bailey is involved with the Society of Critical Care Medicine for over 25 years. That doesn't seem that long. I've been here for over 30, goodness.
Blink of an eye.
Yeah. Served as the Pennsylvania chapter president, received the Dr. Joseph Ray Brown Award for her chapter contributions, and in 2019 became the first emergency medicine trained physician to serve as the president of the Society of Critical Care Medicine. She received the Society's Distinguished Service Award in 2021, and by golly, in 2024 she was honored with the designation of Master of Critical Care Medicine. That's pretty impressive stuff. So please welcome Dr. Heatherlee Bailey. We're in store for a nice presentation tonight.
Well, thank you very much. And it might be a cozy crowd, but it is an important crowd, and I greatly appreciate all of you coming out to hear me speak on what will hopefully be an interesting topic for all of you. And I want to thank John Dolan, the Dolan family, and the foundation for inviting me here to speak. I have to put on my glasses so I can see what I'm doing. Getting old is for the birds. But I want to thank you all for the invitation to speak on emergency medicine and critical care. And I hope that you will find it interesting and informative. My disclosures, I just want to highlight two that are pertinent for this lecture. I am past president of the Society of Critical Care Medicine, and I did do my residency and spent time as faculty at MCP, and you'll understand why I've highlighted those as we get to the end of the lecture. Now, this is a broad topic. I mean, there's entire residencies and fellowships on this topic, and what I've chosen to do is to try and highlight the pertinent issues that we are facing in 2025. So I'm going to cone it down a little bit, and each topic that I talk about, obviously, we could talk for hours, if not days, about each one, but hopefully you'll agree. with what I found to be important. My first question is, who here has been a patient either in the emergency department or the ICU, or has had a family member in one of those locations? Almost the entire room, right? And I'm assuming that all of you had excellent care, that was expedited, the correct diagnosis was made in a timely manner, and you got a positive outcome and good disposition that was rapidly done, right? Sadly, but not surprisingly, that's probably not the case for the majority of the room. So we're going to explore why timely and excellent care is difficult to achieve in both of those locations. And we're going to focus on the importance of the continuum of care, the challenges that we face, innovations that occur, and then at the end, and most importantly, the innovators that have gotten us there. Our goals in the emergency department, they're easy. We want to triage and evaluate individuals in a rapid manner. We want to identify them and treat them, hopefully with evidence-based medicine when it exists, and rapidly disposition them to wherever they need to be it home, be it a floor admission to the operating room or the ICU. And regardless of where you practice, the goals are the same, and that's the same if you're the physician, the nurse, or the patient. This is the path that we hope you follow. Now, in the ICU, the goals are fairly similar, but we tend to do it more in a multidisciplinary group. In the emergency department, if you're in a community hospital, it may just be a physician, an APP, a tech, or a couple of nurses, and that is all you have. Most places in the ICU, at least in the United States, you have a full team, bedside nurses, maybe some APPs, the intensivist, your PharmD, your respiratory therapist, your dietitian, your physical therapist, who truly work as a multidisciplinary team, hopefully delivering evidence-based care that is patient-centered. This is Dr. Saffer. Dr. Saffer was felt to be the grandfather, has been named the grandfather of resuscitation. He's one of the individuals who did a lot of animal studies with dogs and CPR and perfusion. And in 1954, he is the one who focused CPR being both ventilation and compression, that we more or less use a variant of that today. But 50 years ago, he coined the term, the continuum of care, and said, no matter where the patient is, they need to be receiving excellent resuscitative care, whether in the pre-hospital space, the emergency department, and in the ICU. And in his diagram, it was mostly focused in the ICU. I've added those green lines because, as we know, in this day and age, a lot of that resuscitation is occurring long before they get to the ICU, and sometimes long after they leave. I did mention that I'm a member of MCCM for a very long time, almost 30 years now. And this is the motto. You want to give the right care right now, regardless of the location. ICU without walls is another term that we use as well. Now, how do we go about that? Well, we face many challenges, and it doesn't really matter where you are. You could be in an austere environment, working out of a tent in the parking garage during COVID, or in a quaternary institution at the high-level care, such as we are here in the Virginia Hospital Center. While each location is unique and there's slight variant differences in the challenges we face, the overall common themes are the same. And we're going to touch on each of these, starting with the volume and the acuity of the patients that we see, issues with boarding that lead to violence, burnout, and then the challenges that we all face of staffing. In the United States, this is the most recent statistic that I could find, we see over 150 million patients every year in the emergency department. Injury is related to over 40 million individuals, and that accounts for about 47 visits per 100 patients. It's a lot, right? Remember how many people in this room raised their hand? Almost everybody. Almost 18 million people are admitted every year to the hospital, and of that 5 million go to our ICUs, of which 3 million, a little over, come through the emergency department. The emergency department is really the front door of every hospital. But what about our capacity? Right now we have about 6,000 hospitals in the US, little over 900,000 beds. Back in the mid-70s, how many beds were there in the United States? 1.5 million. So we have lost about 600,000 beds. And yet, the volume has dramatically increased. And on every day, we have about 100,000 ICU beds across the country, not including pandemic. When we were in parking garages and cafeterias and hallways, we're running ICUs. The emergency departments are also decreasing. We're down to about 5,500 emergency departments. Over 100 closed in the last 10 years. But when you look at the statistics, the number of units per each department, they've increased by 1,500. And why is that? Well, if you go to most emergency departments, mine included, we've got, some places have paper on the wall with different letters and numbers because we're using hallway beds. We've opened up linen closets to make room for patients. So even though the number of emergency departments has decreased, the number of spaces in those departments have increased because of the volume of patients. And it's not surprising the volume is going up. We're living longer. And not only are we living longer, we are living with more comorbid diseases because healthcare and medicine has improved. So we see plenty of 80 and 90-year-olds in the emergency department in the ICU who have multiple medical problems, multiple comorbid conditions. I took care of a veteran yesterday who was on their 4th malignancy. It's crazy, right? But these are the challenges that we are facing. We are a victim of our own success. When you look at the volume of critical care in the emergency department, it's more than increased by 60% in the last 20 years. The number of resuscitations that occur in the emergency department every year is now tripled compared to what it was. Admissions to the ICU are more than 80% of the last decade, and the length of stay in the ED has gone from an average of about 6 hours, and that number is important. We'll come back to that 6 hours shortly, but has increased sometimes to days waiting for an inpatient bed. This just came out last week, and what it shows year to date, the volume in the emergency department has increased by 4% just this year alone. The number of emergent cases has increased by 6%. And they estimate that in the next 10 years, it's going to increase by another 5%, with the emergent cases increasing even more. The urgent, and a lot of primary care, we do a lot of primary care in the emergency department, is staying relatively static. The figure on your right, got backwards there for a little minute, the ED length of stay, looking at both the volume of the hospital, so the higher volume that you see, the longer it takes to evaluate patients. It's not surprising, those, and the longer they're staying in the emergency department. Well, this is the typical path. For those of you who are not in emergency medicine and don't routinely work in the ED, this is the pathway that typically follows when a critically ill patient comes in. They arrive, you start your resuscitation. Typically fairly early on, you've made the decision that these patients need to be admitted to the ICU, but at the same time, there are competing issues, especially if you're a sole physician, clinician, APP that is working. You're also managing other patients that may be arriving. Lab tests are coming back. You're being handed EKGs to evaluate. And there's the other challenges of once you've decided to admit, well, the ICU may not have a bed. Environmental may not have had a chance to clean the bed that becomes available. There may be no beds in the hospital. We were at over capacity yesterday. I was boarding 10 patients when I walked in at 7 a.m. yesterday morning. Where do you go from there? It makes it challenging. So this is what a typical day in most emergency departments in the US looks like. You've got patients lining the hallway. Typical day in the pandemic. Everybody in this room has lived through the pandemic. We're all here to tell the tale. You may or may not be in medicine. You may or may not have worked in an ED or an ICU, but you remember those days. They were terrifying. Didn't matter if you were the patient, the nurse, the physician, we were all terrified. I talked about that 6 hours. I told you to remember that 6 hours because it's important. And when you patient, doesn't matter if they're critically ill or not, that 6-hour boarding in the emergency department seems to be a universal cutoff. After that 6 hours, mortality increases. And it is related to length of stay of boarding as an independent risk factor. So 6 hours is key. And when you look at boarding and mortality, they did an interesting study. They looked at number needed to harm. Look at the timing. 6 to 8 hours. If you spend over that 6 hours, only need 82 patients. If you're in a hospital that sees 50 to 65,000 patients every year in your emergency department, that doesn't take long to get to. More than 8 to 12 hours, number needed to harm, 1 in 72. Staggering. And the problem is not just in the emergency department. In the ICU, we have issues as well. There's what's called the actual intensive care time. Patients are coming from the emergency department, they're transferring in from other hospitals, they're coming from the operating room, and then there's the time that the patient actually needs to be in the ICU, what's called the ideal ICU length of time, when they need the resuscitation, they need that critical care, they need the nurse at the bedside constantly, the physician caring for them, the APP. But then there's that delay when they've stabilized and they could go to the floor or to step down, but there's nowhere to go because the hospital is full for a variety of reasons, and that's a whole lecture in and of itself. As I said, many of these things we could talk all day about all of them. So in the ICU, the same thing happens. If you are a patient who's waiting for boarding, the longer that you're waiting to leave the ICU in boarding status, your mortality also goes up. And it's estimated that the critical inflection point of hospital occupancy is at about 80%. At that time, the whole hospital does not function as efficiently as it possibly could unless you have someone who is in charge and knows where all the beds are and is making sure that everything is flowing, that environmental is cleaning the beds, that patients are being discharged in an appropriate time frame. But that 80% hospital occupancy is critical. Now, when was the last time your hospital was at only 80%? The only time that I can remember in the last decade was, I'm currently in North Carolina, as you heard, was those first couple weeks of COVID when nobody wanted to come to the hospital. That was probably the last time that I can remember that we were not at 95, 100, 105% capacity. So it's not surprising that we have all these challenges. It's supply and demand. We have a lot more demand than we have capacity. Now, part of it is due to the timing of how hospital systems work. It's known as hospital disequilibrium. Even though care goes on 24 hours a day, we see patients 24 hours a day. They arrive to the emergency department and to the ICU 24 hours a day. A lot of the function of the hospital occurs during banker's hours, right? Patients are being discharged during that time. Environmental comes to clean the beds. Families are working. They can't pick their loved one up until after work. So it's not surprising that we have these challenges because patients are not able to leave the hospital typically until the afternoon. Rehab centers don't have a bed. They're waiting for transfer. So this is one of the challenges. And we all know, it's well documented for decades now, that patients who are boarding, for a critically ill that are boarding, they have longer time on ventilator, worse stroke recovery, longer length of stay, both in the ICU and in the hospital, increasing morbidity and increasing mortality. Another challenge is who is responsible for those critically ill patients that are boarding in the ED. And part of the problem is that nobody's responsible. Both emergency medicine and critical care are shift work. That's the reality of what it is. We are there, sometimes it seems like 24/7, but someone has to be there 24/7, and typically you have an 8, 10, 12-hour shift. You're signing out maybe at your 14th hour, and the patient's been waiting for an ICU bed. But the ICU is full, and they're trying to take care of those patients, and so you have this critically ill patient that may pass through 1, 2, 3, 4 attendings, and nobody's really manning what's going on with the patient. So it's not surprising that these critically ill boarding patients have challenges. And we can talk later about how you manage it in your hospital, because some hospitals manage it very well, and I'm hoping yours is one. My hospital, not so much. We're still working on that. And we'll talk about some of the ways institutions have tried to solve this problem. Another significant problem is violence. Everywhere in the country. And there was just some individual who tried to shoot up Atlanta Hartsfield. Fortunately, he was stopped in time. But it's constantly, every day on the news, we are bombarded with violence everywhere we go. But it is increasing in the hospitals, and the attacks on hospital workers are higher than anywhere else. We have a significant problem, non-fatal injuries, healthcare workers, almost 10-to-1 compared to any other workforce. Did you realize that? No. My fellow emergency department team does, and my ICU people, yes, because we see it every day. And a lot of it is never reported, because if I had to report every time that I had an issue, especially when I worked in Philadelphia, I never would have gotten anything done, right? So, but it is a significant problem, and this is non-fatal injuries. And when you look at the non-fatal injuries, healthcare in the dark blue, everybody else in the light color, days lost of work, significant, and it's increasing. Everybody else is more or less staying the same. We are going off the charts, and this is pre-pandemic data. It got worse then. So unfortunately, in the emergency department and the ICU, we are even more vulnerable than most other areas of the hospital. Emergency department, people can come right in. You know, we have those ambulance doors that don't have security, don't have metal detectors. I don't have metal detectors at my hospital. I don't know if your ICU or your emergency department have metal detectors, but there's easy access. We take care of critically ill patients, typically on their and their family's worst day. It is not surprising why people turn their despair and their issues towards us, because we have just given them bad news, whether they're in the ICU or in the emergency department. So we unfortunately take the brunt of this, as do our bedside nurses. This was introduced, a workforce violence. So many other fields have a penalty if you attack them. You know, TSA, there's signs all over the place. You know, if you even say something inappropriate to TSA that, oh, I may have a bomb, not the best idea, you get in serious trouble. They will haul you off. You don't get to get on your plane. This was introduced back in 2019. It was passed in the House. It has never been brought to the Senate floor. And Lord knows when anything will be brought to the Senate floor in the near future. Multiple societies are trying to address this. We are having conferences, going to Washington, trying to lobby to get this passed, because you should not have to worry about your life when you're at work. This was from a conference that I found. If you look at the name badges, It's not their name. It's saying what happened to them, and the one you can see is choked and punched. I don't understand people's logic and patients' logic. Why are we the target? We're trying to help them. So it's not surprising when you add all of these things together, increased volume, increased acuity, the boarding challenges, the violence that we all face, that burnout is a significant problem throughout all of medicine. And it was going on long before COVID and pandemic. This is from 2014, and I liked this one because it has both emergency medicine and critical care at the top, both over 50%, so I have a 105% chance of burning out. Some days I have definitely felt that. What might interest you to know is that burnout didn't start with medicine. Does anyone know what the original studies on burnout were from in the 1970s? No. No. It was Maslach and Friedrich Berger. They were doing working separately. One of them was studying individuals who abused substances, and the other one was studying lawyers. That's where the original data comes from. But the drivers of burnout, you're all familiar with them, that EHR. Right? I mean, the great things about the EHR is that you can read it, sort of. It doesn't necessarily make sense, but it at least is legible. But all of these things, we take care of the critically ill that are trying to die. Our schedules are terrible. Someone has to be there 24/7. The administration may or may not understand what we do and may or may not be helpful. But when asked, that EHR and the level of paperwork is the #1 driver of burnout, followed by the work hours, followed by our schedules and on-call, because there's only so many Christmases or Thanksgivings or children's birthdays or soccer games that anybody really wants to miss. It's also important to know that the WHO has declared burnout a workplace hazard. It actually has an ICD-10 and 11 code. So it's recognized, but did any of you know that before this slide? No, right? Because nobody was willing to tell us that. This is a workplace hazard and it has a code. Important to know. And then we hit COVID and pandemic. I don't think I need to say much more about that, but because of the focus on emergency medicine and critical care, Merriam-Webster put out new words every year. Intensivist became a household lexicon, right? Never before did anyone outside of medicine know what an intensivist was. So one of the few good things is that they now know what we do. I think they've forgotten now, but at least at one point they did. And this is a post-COVID study looking at the high levels of burnout. Nurses in the lighter color, physicians in the dark color, essentially pretty equivalent except for one aspect. And this was in over 20,000 respondents. And what is it? The emotional exhaustion. Remember those early days of COVID? No one could get in or out. It was our bedside nurses who took the brunt with the patients. They were there night and day, holding their hands, being the surrogate family. And there's only so long that you can do that without completely decompensating. So it's not surprising that when you add all of that together, we have had a significant attrition in staff of all levels across healthcare, but especially in our bedside nurses. And this started long before pandemic, but has been exacerbated during it. Quits and hires at the bottom, relatively stable. The number of openings available for bedside nurses, skyrocketing. Same with physicians. Estimate that in 11 short years, we will be 86,000 doctors short. And that's just in the US. Who are you going to go see? Now this was from 2 years ago they put this out, but 2030 staffing needs. In 5 short years, the entire world will be 6 million nurses short. That is terrifying. And they estimated at the time, this was from 2 years ago, that if every nursing school in the world would need to increase each class by 8% to attempt to meet that shortage. That clearly hasn't happened. And it's not just nurses, it's all levels of healthcare providers, with one minor exception, and that's our administrators. So if you can look in 1980, exponential rise in the number of hospital administrators, and also dramatic increase in hospital spending. And then we need to tackle communication, because those are all challenges that we have, all those others, just more so for the emergency medicine and the intensive care units, but communication is a problem for everyone. And it's patient to physician, patient to nurse, nurse to physician, emergency department to the ICU, to the primary care. We don't listen to each other, right? Just yesterday, my intern was trying to present a kidney stone patient to the urologist. And I tried to prep her and say, all they want to know is, what's the problem? Are they sick, not sick? Do they need the operating room? That's really, and so she's giving this whole medicine presentation, and I could hear them just saying to her, just stop, tell me that. So we're not good listeners. But you need good communication, because one of the major issues where medical errors occur is in handoffs, because we don't listen, or we're just too busy and there's too many patients and you forget we are human. So handoffs and errors go hand in hand. No, sorry for the pun. But when you look at the literature, depending on who you read, it's anywhere from as low as 23% of errors occur in handoffs to as high as 80%. It's all over the place. But it's one of the more frequent causes of a harmful medical error. Something gets missed, antibiotics don't get given, something's not addressed, and there's increasing morbidity, mortality, and cost. I think this is a fabulous quote. And it's not just in medicine, right? It's in home life too. My husband and I accuse each other of this all the time. So I now want to focus on some of the more positives of the things that are going on now and where we're headed. And we're going to touch on all of these. First, we're going to start with something that is not necessarily in medicine. It's everywhere. Now, I'd be willing to bet that almost everybody in here has a phone on them, right? And I would say the majority of the room probably has some type of smartphone. Now, this is my public service message for the group. Has everybody filled out their medical information on their phone? Yes. So this group is better than most. If not, I see a couple no's. The reason you do that is because when you click on your phone, if you look and you open it, at least on the Apple, there's this little emergency button down at the bottom. So you don't need to know the code. When you come into my emergency department unresponsive and unable to talk, you may or may not have ID on you, but you darn sure probably have your phone attached to you. I'm going to take your phone and I'm going to hit that emergency button, and it's going to then tell me a little medical ID, and then I can open up and see who you are, what kind of medical problems you have, what allergies you may have, what medicines you're on, and most importantly, your contact. And it's all well and good. You say, oh, well, there's the EHR. The EHR, they're very good and they're very helpful, but A, you may not be in your own system. You may be traveling. You may be on the other side of the country. There are 3 main EHRs in the United States. There's Epic, there's Cerner, and then there's CPRS through the VA. They don't talk to each other, right? So if you say, oh, it's in my medical record, well, it's in my medical record in Epic, but not in CPRS. So please, I beg you, if you have it, fill it out so that way, God forbid, if you're somewhere and you're not able to give information, somebody can call your family and let them know what's going on with you. But the smartphones and the smartwatches are really helpful. I'd say easily once a week, I have someone who comes in and says, my watch, my phone told me I need to go to the ER. And I would say easily in the last 5 years, every single watch/phone who said the patient was having an arrhythmia was correct. Pretty cool. And it wasn't designed for medicine. Multiple studies out there looking at all different kinds of things, from blood pressure to sleep habits, can be really helpful. It's also a little bit big brother, but it's okay if it helps the patient. Now, some other equipment, now I'd say most of the cohort in the room is similar in age to me. You remember Star Trek and Bones with his tricorder. I mean, I remember that thing, I'm like, that is so cool. You can scan it over someone, tell what the problem is. Now, this is from 1985 or 86. This was Star Trek 4, and it came out. And the quote, what's the matter with you? I'm on kidney dialysis. Oh, my God, what is that, the Dark Ages? Well, you know, now, unfortunately, we still have thousands of patients on kidney dialysis, but we do have something that's similar to the tricorder. We have the handheld ultrasound. And I was just telling the group before the lecture started, I had 2 house staff just the other day. There's senior residents planning to go into cardiology. You know, I am at the Duke system. Most go into cardiology. And they were discussing which handheld ultrasound they were going to buy when they became fellows. And I was thinking, dang, man, fellows must be getting paid pretty well now. But it's a really fascinating concept. You can, in the palm of your hand, ultrasound and make these diagnoses. Now, for years, we've been using ultrasound in trauma, using it for procedure safety, all of these other things. A study recently came out in MCCM looking at point-of-care ultrasound and the evaluation of shock, and showed that it can be helpful. It influences what medicines we use, it influences fluid resuscitation, it can help with lactate clearance, and decreases overall testing, duration of medications being given, and also patients crumping on the floor with RRTs and overall mortality. Great stuff. When you look at the EHR versus manual screening, in the first 4 to 6 hours of patient evaluation, it's pretty similar of identifying those patients with sepsis, but the longer that the patient is in the system, it's much more likely that the EHR is going to pick up the patient who's developing sepsis versus the staff, because they just have too much else to do. And using machine learning, it's found that you can predict sepsis even before it is starting, in those first early hours. Think about that. If we can identify every patient before they were in septic shock and intervene, what a difference that would make in outcome. The EHR sepsis alerts have been shown to improve identifying and meeting your SEP1 bundles. For those of you who know what the SEP1 bundle is, we're all mandated across the country. It's been shown to improve the IV fluid, getting your blood cultures, delivering your antibiotics, identifying your lactate. So that's great for reimbursement and meeting that metric, but more importantly, it decreases mortality risk. So it does help the patient. And using EHRs to alert individuals, this was EHR alerting both the ED physician and the pharmacist at the same time that there was a patient who potentially had sepsis in the emergency department. So antibiotics were ordered sooner, antibiotics were administered sooner, and overall patient mortality improved. But we all know of alert fatigue. In the emergency department, in the ICU, alarms are going off constantly. And I know many of you, like me, I ignore most alarms unless it's a ventilator or a dropping pulse ox. Or if someone says, oh my God, he's in VTAC, well then I'm gonna get up and go, right? But you have to selectively pick out your alarms. So these EHR alerts only do any good if someone then goes and evaluates the patient. So this was not only an alert, but a nudge. Did you go evaluate the patient? And when they did go and evaluate the patient, it showed improvement in overall length of stay in both the hospital and in the ICU, and in turn, improved mortality. But there's something to be said for the experienced, especially nurse, who has been there and done that and seen everything. Unfortunately, they are becoming less and less because they are retiring or changing jobs because they're burned out. But our experienced triage nurses and our experienced physicians as well can look at you and say, even though your vital signs may not be bad, you're ill. You need to come back now. So and you all know, you've got certain nurses who, if that nurse says to you, you need to come now, you go. You don't wait. There's some agreement in the room. But we are human, and with our nurses retiring and less experienced individuals who are evaluating patients, this was using an augmented triage algorithm, and they called it KATE. And they compared it to nurse triage. Now, they didn't say how experienced the nurse triage was, but the nurse triage for these patients was only about 60% accurate. KATE did better at 75%, but even KATE was not perfect. So there is room for improvement. Now, what about computer versus computer? This is a great study that just came out this year. This is looking at the EKG computer that prints out on your EKG the read versus an AI algorithm. And what it shows, and you may not be able to see, but the computer, the EKG computer says normal EKG in 40% of the time. However, it was an occlusive MI, so a missed diagnosis, versus high certainty using this new algorithm. Pretty fascinating. And this is the EKG that they showed. Now, I don't know how many of you read EKGs frequently, but yesterday I stopped counting because I was curious as to how many EKGs I get handed. And by 11 o'clock, and it was a slow Monday morning, it was really weird. It was not as busy as usual. I had seen and been handed 25 EKGs by 11 a.m., and I got there at 7. And for the first hour, there was not a lot going on. Like I said, it was a weird Monday. And I make an effort to look at every EKG because I don't want to miss. Well, I mean, the STEMI is in general pretty easy to say. Typically, the computer gets it right, and it's pretty obvious. But it's not really STEMI that we're just looking for. You need to look for ischemia. And what this shows, this was read as normal by the cardiology EKG computer. But when you see here, and oh, my light doesn't really project well, but up in this top V1 and V2, there is subtle ST depression, which you can see highlighted in the AI algorithm. And this individual had occlusive MI, and on cath, they were taken emergently to cath, had a 95% occluded mid-RCA with that EKG. When you're on your 8th hour and your 50th EKG, I don't know that I'm going to catch that, right? So we definitely need help. And the algorithm, and I have nothing to do with it, but it's called Queen of Hearts. And so you can download that, put that on your phone. But I have no vested interest or anything in it other than in making the right diagnosis for the patient. So what about AI in the emergency department? Well, there's plenty of studies that suggest that it improves accuracy and speed in triage. That seems to make sense. And it's as good, if not better, in predicting who needs to be admitted, who needs the ICU, and who's going to develop sepsis than the initial clinician evaluation. But there are significant concerns. What is the quality of the data that is being input? Remember, AI uses the data that it's given. And if it's only given part of the data, there's concern for bias. And whole groups may be ignored and not identified. There's the ethical concerns of patient information being released. And then there's, of course, clinician trust and believing that, is this doing the right thing, or is AI trying to take over the world? In the ICU as well, this study also just came out in JAMA, looked at the number of AI studies being done in the ICU. The darker colors are anything from 2020 on, and you can see the size of the circle is dramatically increased in the last 4 to 5 years. But when you look at what these studies are showing, these first few, it's just models where the potential, very, very few are on clinical outcomes or on integrating the model. So we are nowhere near using this solely for care. There's the potential, but we still have almost no evidence-based medicine on this. And in the emergency department, the interventions that have been shown using models and AI to improve care, we have an improvement in triage by using these models, by using point-of-care testing that also improves patient care, and by using fast track that speeds patients through the emergency department and takes them out of the group so that you can focus on the critically ill patient. Another way you do that is by using telemedicine. Now, in the VA, pre-pandemic, we took care of about 2,500 patients across the country every day by telemedicine. During the beginning of COVID, it went from 2,500 to 25,000 cases daily. It's a lot of patients. And you can see 2 million for all of 2019, over 9 million in the first 4 months of 2020. Staggering. And we had never used telehealth in the emergency department until COVID. And we did it for a variety of reasons. One was we wanted to keep people out of the ER. I mean, nobody wanted to go to the ER anyway, but we wanted to keep patients who didn't need to be there out of the emergency department. So we wanted to improve our veterans' access to care, specifically those who were not able to get their prescriptions. Pharmacies were closed, the Postal Service wasn't necessarily getting them their medicines. And for those individuals who were quarantined, our nurses and our doctors, if you had that exposure, remember the beginning of COVID, if you were exposed, you were quarantined as well. So you were able to still help the system by working. And I did a lot of telehealth those first couple of months of COVID. And the one thing I remember clearly was I took care of a lot of poison ivy by video phone because everybody else was home. And in North Carolina, March, April, May, June, beautiful weather, so everybody who could was outside cleaning out their yards. And I must have written 10 prescriptions for prednisone every day for somebody who was covered in poison ivy. Now in the ICU, tele-ICU has been around for a very long time as well, and there are multiple different models. And I know, do you guys use tele-ICU here? No. But there are multiple models. There are some remote facilities that need 24/7 coverage by telehealth because they don't have an intensivist. They may be led by an NP or an APP. There are others that need it for certain hours of the day, some just for targeted intervention for specialty cases such as stroke care. And there's multiple different iterations of this. And some places have that's on site. University of Penn has a bunker where they have doctors and nurses that cover their entire system for the overnight hours. And then there's places like Emory who've really got it figured out. Not only do they use telemedicine at night for coverage, they send their telemedicine team to Australia.
Wow.
And so they're in Australia working day shift in Australia, covering night shift here. So completely eliminates that day-night dysynchrony that night shift workers get. Who wants to go work at Emory in the tele-ICU, right? Go to Australia for a couple weeks at a time. So there's all different kinds of iterations of that. And that's because we need more staff. We need more help. And the studies showed that for change in 60-day mortality for each additional nurse, decreased mortality of patients. And having an intensivist present decreased mortality by 16%. But the convert is also true. If you didn't have an intensivist or you have more patients per nurse, mortality rises. And this is some of the reasons that areas around the country have created these resuscitative care units with the focus on giving right care right now for the individual regardless of where they are. They typically require dedicated teams, but it allows for the continuum of care from the time the patient enters the hospital system. And many times it requires creating a novel space, such as what happened in pandemic, where we turned parking lots and cafeterias and hallways and conference rooms into ICUs. Now, there are a few dedicated ED ICUs around the country. This is Michigan's data. And you can see when Michigan opened up their ED ICU, dramatic drop in mortality. And it wasn't just in the patients cared for in the ED ICU, it was in all patients in all ICUs in the entire system, because now they had somewhere else that they could go and be resuscitated. And Michigan's setup has, other than their trauma patients who go directly to the OR or the trauma ICU, they go, if there's not an immediate bed in the appropriate ICU, they go to the ED ICU where they may receive all of their care. They can do everything in that ED ICU that can be done in any of their other ICUs. So that patient may then be discharged to floor or even discharged home. But if they're there for a period of time and a bed opens up in the appropriate dedicated unit, the patient then goes to that ICU. But most of us don't have the space, the time, the money, or the staff. So other places, and this is out of Stanford, what they've created is using EM intensivists in the emergency department to help guide those patients that need resuscitation. And what they show is when they use this cohort, dramatic improvement in overall mortality in that cohort. And when they spread it out and looked at all the different levels of care, from those that were mildly critically ill, had low SOFA scores, and then the very high SOFA scores, the ED intensivists didn't really contribute much. It was those moderately ill individuals that were critically ill that an intervention was needed and it occurred. So that is the individuals that were able to be impacted by these ED intensivists, because they were moderately sick and would have progressed had they not received the care. This is another study that looked at using telemedicine in the emergency department to monitor the boarders. And they had a dedicated team. I mean, the EDs are already monitored. They've got the equipment. And so they put these patients on monitor, and they had a dedicated team that would monitor them by telehealth and either send someone from their team if there was a problem, or alert the ED to say, hey, this individual's vital signs are becoming abnormal. Dramatically improve mortality, improve their level of care, decrease the overall length of stay. Interestingly, though, look at the boarding in the emergency department. It actually doubled the time of boarding, and you're thinking, well, why is that? Well, it was because they were receiving dedicated care, and the patient improved and then was able to be downgraded to a lower level of care and sometimes discharged home. So even though the boarding did increase, it was an improvement in overall patient care. And to summarize this area, I think it's really the chain of prevention. It includes all of us. It includes us as the clinicians, We need to pay attention to our alarms. The EHR, no matter how painful it is, can be useful when it is alerting us for the appropriate information. And AI does seem in many instances that it will be helpful, but we need more evidence. But one of the most important things that we need to focus on, and this is another quote from Dr. Saffer, the most sophisticated intensive care becomes unnecessary, expensive terminal care when the pre-ICU system fails. Very valid statement. So I know a lot of you are like, wow, that's a lot of information in a short period of time, and it's really making my head hurt. But the last area I want to focus on is the innovators. Because how do we get from challenges to these amazing interventions? Is someone has to come up with the idea. And you may know some of these innovators that I'm going to tell you about. This is also another great quote from Grace Hopper that you may be aware of. It's, "We've always done it that way." How many times does that get uttered at this institution? We do it this way. When I first went to Duke 15 plus years ago, on day 2, I couldn't get out of the parking garage for the second day. I went back to the parking garage guy, and I explained my problem, and he said, "Ma'am, you have to realize there's the right way, there's the wrong way, and there's the Duke way. It may be the right way, it could be the wrong way, but it is definitely the Duke way." He said, and if you understand that, things will go much better. So I'm sure at this hospital system you have some of those as well. But challenge that. It is not always the way we've done it. So the first innovator you should all know. This is why we are here. And we had some interesting discussions, and you said you didn't learn some of these things about your father until you were reading and writing his obituary, which is sad, but he truly sounds like an amazing man who identified gaps, creating field hospitals on Omaha Beach, to the reason for this lecture of identifying the fact that by educating students and pre-hospital individuals, you improve their knowledge and in turn improve patient care. That's what we're looking for, right? That's why we're all here. So those of you in emergency medicine hopefully know Dr. David K. Wagner. He was thought to be the grandfather or one of the grandfathers of emergency medicine, and he was my chair at MCP. He created the first department of emergency medicine and the first full 3-year emergency medicine residency. Now, he was a pediatric surgeon by trade. He started working in the emergency department nights and weekends because they were willing to pay him, and the story changes as to how much, but somewhere between $1.50 an hour and $5 an hour extra on top of his pay as a pediatric surgeon. And he had young children and he had debts that he needed to pay, and so he started working in the emergency, and it was a room at that time. And we used to have a picture of it, and I can't find a slide of it, but people would go to the emergency room, and there was a sign that said, "Ring the bell for service." And so you would ring the bell, and someone would let you in. And he quickly realized that over time that this was an area that people really needed to understand and needed to focus on, because this was a specific cohort of patients that needed acute resuscitation, but that the physician caring for them had to be able to do many different things. They had to be able to take care of a broken ankle, take care of a gunshot wound, someone who's coding. And so it was through that he created, with many others, and here's some other EM leaders, the field of emergency medicine. Judy Tintinelli was internal medicine trained, and during her medical school rotation, she spent a time in the emergency department, and she thought that it was so amazing that she did as many different rotations during her internal medicine residency so that she would be well versed, and then she ended up at the University of North Carolina. Her textbook first came out in 1978. So this is the late 60s and early 70s. Peter Rosen was also a surgeon by training. He got into emergency medicine for two reasons. One, both he and also his father had myocardial infarctions, not at the same time. His father unfortunately passed away, and he said that both the care that his father and he received were less than adequate, and so he felt the need to create the specialty of emergency medicine. And then the last book is The Procedures of Emergency Medicine. Roberts and Hedges, both early graduates of Medical College of Pennsylvania. Jim Roberts was at MCP the entire time, and he was a character. But they realized early on that, I know that we all know that there was no Google, no internet, no nothing. You had to look things up in a book. And people would show up, and you would need to know how to put in a chest tube or float a transvenous pacer or take something out of someone's ear. And so they wrote the original Procedures in Emergency Medicine. So all of these innovators, they didn't start out to create a new specialty, but they saw a need, and they took the next step. Now, this was the early 60s and 70s that this was starting. Same time as critical care, and I'm going to get to critical care in just a moment. And there was a big political issue about why emergency medicine and critical care, never the two shall meet. It's a discussion for afterwards when we have champagne. But when Dr. Wagner was president of ABEM, he talked about the importance of the continuum of care and the recognition that emergency medicine, it makes sense. We should just continue the resuscitation. And I love this in his presidential address in 1982. He says, they will negotiate in the near future. Well, you'll see when emergency medicine finally got to be boarded in critical care. It was several decades later. But it's not just the specialty. There's also societies, and this is the early leaders of the Society of Critical Care Medicine. Peter Saffer, who I've already mentioned about, he's from Vienna, trained as a surgeon and anesthesiologist. William and Norma Shoemaker. William was trained at Hahnemann. Aki Grenvik, who went on to create the first critical care department in the country at University of Pittsburgh. He was from Switzerland and trained as a surgeon and anesthesiologist. And then Max Harry Weil, the first president of the Society of Critical Care Medicine, was a cardiologist also from Switzerland, based in California. And they got together, much like the leaders who created emergency medicine, and said, critical care at that time was siloed, and in many places it still is. But they realized that they needed a multi-professional society and place where people could come together from anyone who cared for critical care patients, be you the bedside nurse, a nurse anesthetist, the respiratory therapist, the pharmacist, and brought them all into one location. And I started at SCCM. My first meeting was in 1998, and long before emergency medicine was recognized for anything. And they welcomed me. They thought I was a little bit odd, which is okay, but they were happy to have me there because I was interested in the care of the patient. And then the last set of innovators that I'm going to introduce you to, I would bet that no one knows unless they're from New Jersey and they spent some time in pre-hospital care. And these are my parents. So Richard and Jessie Bailey. My mother was a nurse, and she worked in some of the first ICUs in the country in California when she spent a year or two out there. My father was a nuclear chemist by trade. And in December of 1973, they were involved in a very serious car accident. They were hit by a drunk driver late at night, and they were rolled over in a ditch. Now, the good thing about that time frame, cars were big and heavy. That's probably the only reason my parents survived. My father had to crawl out the window to then try and extricate my mother, who was pinned in the driver's seat. So they were picked up by their local volunteer first aid squad. Remember, this is the early 70s. All of this was all occurring at the same time. And my mother was so appalled by the lack of knowledge. They were all well-meaning, but she knew more about the care she needed than any of the people who showed up in the ambulance. And so she was so appalled that when they recovered, My mother joined our local first aid squad in May of 1974. You can say the rest of it is history. But they were so invested in care that they went on. Now, my father, I can still remember as a young child, my father couldn't stand the sight of blood, so it's very entertaining to me that he went on to do what he did. So this is, again, 1974. And at that same time, remember, emergency medicine, critical care, all starting, and many of you recognize Emergency Squad 51. The first paramedic show started in 1972. At that time, you know how many paramedic units there were in the country? 12. 12, not 12 states, 12 paramedic units, and 2 of which were in LA, and all of their original cases were based on cases that they had. By the time the show was done, in 1979, every state had a paramedic program. In fact, the knowledge that was taught to the public and the importance of early care, the public demanded this, but the difference that they made, they actually have stuff from Emergency Squad 51 in the Smithsonian, but not in the entertainment section, in the public safety section, because they made such a difference. So during that time, in 1976, they created the first class in the state of New Jersey. My mother was in the very first class of New Jersey in 1976. Her paramedic number, 38. My father was in the second class in the state of New Jersey. His number was number 77. What's even funnier and more ironic was that they did their training in Newark, New Jersey, in the old Martland Hospital, and that's where I went to medical school several decades later. But it was all volunteer. And they rode throughout, all of the county. And they would take care of both our area in Pennington, but then the paramedics in the area would take an ambulance and they would rotate and cover the city of Trenton. And they had some really wild stories that I wish that they had written down. But it doesn't end there. My parents realized that they had all this great resuscitation equipment, but they realized that if they got to the scene and the patient was in cardiac arrest and someone wasn't doing CPR, it didn't matter. All of that great equipment that they had and the great drugs, and for those of you who remember isoproterenol, everybody got it in those days, it didn't work. So unless the patient coded in front of them and they could use their life-saving equipment at that time, or someone was doing CPR at the time of arrival, that was the only time it made a difference. So they then decided that they were going to teach CPR to everybody. So they created and worked with the American Heart Association, and at the time in the mid-70s, CPR to the layperson, you know how many hours it was? 12. Well, who is going to spend 12 hours just trying to learn a technique? So they created and protocoled the original 4-hour CPR course out of our first aid squad in Pennington, New Jersey. And they then went on to teach thousands of people throughout our community and throughout the state. And my brother and I were right there with them. And in fact, the community was so grateful that they got to be grand marshals of our memorial parade one year because of their dedication to the community. Now, as I said, my brother and I, we literally grew up in the back of an ambulance. And the good news is the good and the bad is there's not a lot of pictures because, not everybody had a camera with them. So there are just a few handful of pictures. And it's not surprising growing up in the back of an ambulance and doing the things that we did and seeing all of the things. We had a Bailey crew night every Thursday night. The 4 of us would ride all through high school. That I went into emergency medicine when I went to medical school. There was nothing else for me. But even at that time in the early 90s, emergency medicine was still a very uncertain field, and people tried to talk me out of it, and I said, are you kidding? It's the best place to be. It's where all the cool stuff happens. And so I was very fortunate that I matched at the Medical College of Pennsylvania. Remember back to Dave Wagner, the original program. This is the picture from above. You can see the hospital, our helipad landing. Now what you can't appreciate here, if you're not familiar with Philadelphia, is this sits up on a hill where, for Philadelphia speak, the Boulevard and the Schuylkill, right where they split. And for those of you who are not familiar with Philadelphia, Route 1 and 76, this is where they split. We sit up right up on top of the hill. There's a significant drop right next to that helicopter pad, and actually these little white things right next to the helipad, the ED entrance was right there. That's our liquid oxygen tanks. Not sure what engineer came up with that, but anyway, we never had an issue. But I was fortunate and I matched at MCP. Amazing training program, and in 36 months, we did 9 months of ICU. And this is where I learned to love and appreciate critical care. Now, we had several hospitals that we worked in, and the health system, Mercy Misericordia, was built in the late 1800s, I think. But not only were we in the emergency department, we ran that ICU. Because Dave Wagner realized early on, back in the 80s, we had worked in hospitals and we had our own ICU. And it was the only ICU in the hospital. In fact, the gunshot wound patients that came there came to us because the surgery team didn't want to care for them. So we cared for everybody, and this is where I developed my love of critical care. And it's the amazing being able to watch the pathology. And so I started asking the question, well, I want to do a fellowship in critical care. And they're like, you can't. I'm like, why not? And they're like, well, you're emergency medicine. And I said, so? And it's a long, convoluted story of how we got there, but there was others across the country, and we fought, and we argued to anyone who was willing to listen, and I certainly didn't do this alone, but people like Kyle Gunnarsson and Jay Falk and Manny Rivers, Julie McLaughlin, we all banded together and we persisted, I think, and we just wore them down. And finally, I'm happy to say that emergency medicine went from being the kid that nobody wanted to the kid that everybody wanted, and we are the only specialty that has the choice of which pathway you want to go in. And as of 2024, the colleagues below me have been able to go through these fellowships and get boarded in critical care in the US, and those are the numbers along the bottom as of 2024, how many EM intensivists there are in those particular specialties. So we're back to that question. Think about, you all laughed when I asked you, did you all have expedient, excellent care? What would you do different? And how would you do that? The majority of the innovators that I told you about, myself included, we didn't set out to change medicine. But because of persistence and seeing a gap and wanting to improve things, all of us, from Dr. Dolan, who we're here to honor, to WAGs and all of the leaders of SCCM, to my parents, you can make a difference. You don't have to be at the high-level academic institution, a full professor. You just have to want to make a difference. So I ask you, and it doesn't have to be in medicine. For those of you not in medicine, or maybe you have something else that you're passionate about, if you see something that you can change, and it'll be a change for the better, I urge you, be the ripple of change. So I hope you've enjoyed this presentation. I know it was very fast. I know there was a lot of information in there and just the highlights, but it's important to remember there are multiple challenges, but we all have those same challenges. We need to work with each other better. Clear communication is absolutely critical, both in our personal lives and in our professional lives, to make sure that our patients have good outcomes. There are some advances in technology that will hopefully improve care. And I ask you to challenge the status quo. If you can do it better, don't stay with that because we've always done it that way. And with that, I thank you for your attention. I appreciate you listening. Thank you.
I have a question for you. The same issues which you described in the American system present in Europe, for instance? And if so, is there anything you've learned from them that can be applied here?
So an excellent question. And they are struggling with some of the issues. They are struggling with boarding of patients in their emergency departments. And their training system is different, but they are also struggling with lack of nurses. They don't have as much challenge with physician coverage, but they are also struggling with the nursing needs. And I don't know that anybody has a good answer. You know, for years, multiple hospitals, both in our country and in Europe, have brought nurses in from the Philippines and other areas. But during COVID and pandemic, that pathway was shut down, and it has not seemed to reopen for whether it's because people don't want to go into healthcare because of what happened in COVID. It's unclear, and unfortunately, I wish I had a better answer for you. I do think that there are some solutions with using telemedicine and telecritical care. You know, during COVID, we had a staggered training where you would have one intensivist and maybe one or two ICU nurses who were manning hundreds of patients, where they had physicians and nurses who worked in other specialties working underneath them. So that is in crisis mode, but that's not sustainable. So it's an excellent question, and I wish I had a better answer for you. I'm all ears if you have one.
Are they having the same burnout problems?
Yes. Yes, especially in Europe, and not just in Europe, in India and South America as well. I have a colleague who's in Brazil, and their boarding is even worse than ours. They have, on average, patients waiting in their community hospitals, their public service hospitals, 3 days to get to an ICU, and their rate of mortality is astronomical. So we are not great, but we are not the worst. And they're struggling with what they can do. Part of it is lack of staffing, part of it is lack of beds. We talked about we have less beds now. You know, we're 600,000 less than before, but I don't know that we would even have the staff to cover them at this point.
The gentleman asked my very question, so I just want to personally thank you for your lecture. It was quite enlightening.
Oh, thank you. I'm hoping it was not too depressing in the beginning, but it's important to know, and I thank you for your comment.
Since you have a boarding problem and delay, I was an infantry combat medic during the Vietnam War in 1968 at Battle Offensive. We were at 10 times faster. We moved very fast. Obviously, we didn't have legal problems that we do here, but we didn't have the paperwork either. But we did take care of patients, and as you know, from Vietnam, we had the helicopters, and we saved a lot of people and transferred patients from Vietnam to Japan. And why don't we copy that? If you work for the VA, why don't we copy the Army?
So first off, thank you for your service. And we do, to a point, you know, rapid triage and rapid moving of patients is still followed to this day. And what's interesting was that the golden hour has been around since 1918, and Crowley, who created, you know, shock trauma in Maryland, and used that concept of the importance of taking patients who are critically ill and bringing them into care. The problem is we have so many critically ill and injured patients that the capacity is not enough to meet the demand, and we need more providers at all levels, you know, from environmental to clean the rooms so that we can move patients out of the emergency department. The VA is in a staffing crisis. We've had many individuals who've left the federal government employment for a variety of reasons, and so we have large openings, including, right now, to try and get turnaround time for teleradiology at night. For CT, it's gone from within an hour to, unfortunately, all shift. I don't know what the answer is, but I think we need more people, and we need more funding and more support, and we need administrators to understand what the challenge is. And I don't know how to go about doing that other than to keep talking to them. Do you have any suggestions? Because I agree with you, getting the patients there to care faster.
Army trained medics, but we all go to Fort St. Hilton. It's an amazing training. They really spend the time. And you can have advanced. I had a medic, a combat medic with a field, and I was trained in surgery here training. We worked very well. Why don't we use that? Why don't we? And it's only a year versus 4 years for a nurse or whatever, or why the civilians do the same time. Why don't we take a look at what the Army does in Fort St. Houston?
Well, the paramedic training, it depends on where you train, and some of it is just a year. It depends on what state you're in. Every state is different. There's a basic minimum requirement at the national level, but each state has different requirements, and some states do only require, I haven't looked at the paramedic training in a long time, but there was in the past, it was just a year of training to try and do that. We actually repurpose our combat medics in our VA. We use combat medics now, we call them ICT. I don't remember what the I and the C are, but the technicians, and they are amazingly helpful. They can help with splint, they can help with suturing, and they're part of our Geri Vet program. We are a level 1 geriatric emergency department. I think we're the first in the state of North Carolina. And so we screen all of our veterans, and many of you will be happy to hear we use 75 instead of 65 as the age of geriatric. And they all, which I'm thrilled because the closer I get to 65, I'm happy with that. But they screen them, and we can send them out to their houses to make sure that they're safe, or to follow up on them if they have a COPD exacerbation or cellulitis, or we want to make sure that they're safe at home. So we are reusing our combat medics who've come to us. So we do try and do that, but I think it's an excellent suggestion.
I enjoyed your presentation very much. I was really interested in what you talked about, the violence in the hospital. I'm a former patient relations manager at a local hospital, and I have a graduate degree in criminal justice, and I was employed by the hospital as a patient relations manager. And as soon as they found out my background, I was called to the emergency room a lot because there was a lot of violent or pre-violent episodes, and the staff didn't know how to handle it. They were trying to, as you said, treat people that were in critical condition and having emergencies. So I ended up in a multifaceted role. When I was hired, I wasn't hired to do that. I was hired to do, grievances, work with the CEO, and my role ended up quickly changing when they found out my background, because in criminal justice, my role was a victim specialist, so I worked with victims of crime. So I ended up going through the emergency room, on the floors, patients that got disrupted, nurses didn't know how to handle it, they weren't able to provide care, and I ended up trying to ward off something criminal happening before it did. And so I'm just curious, at your hospital, do you have a person that does that, or how do you handle, do the violent episodes occur, or do you have somebody that can ward them off before they actually happen, so the practitioners and the doctors and nurses can get to the care that they need for the patient?
So an excellent example that you gave, and thank you, because we desperately need more of you. The answer is yes, we have violent episodes, and no, we do not have a dedicated person, but we have all been mandated to go through training, both the online TMS type of training, and then we have also have different tiers that they have in the VA, and because we are a critical area that is high prone to violence, we are required to do hands-on training for de-escalation. So we are all in theory trained for that role, but we don't have a dedicated separate individual, but that would be a wonderful resource. Thank you for sharing.
Thank you. One of the purpose of this lecture was to bring people to this community that they wouldn't normally see, and topics they wouldn't normally hear about, and I think that occurred tonight, and I thank you very much.
Oh, thank you. I think we're supposed to go forward so they can get a picture.